I'm Dr. Natalie Crawford. I'm a board certified OBGYN and REI. So I'm a fertility doctor and I talk about Clomid every day. I get so many questions about this. And today I just want to take a quick minute to tell you what Clomid is, how it works, when we use it, and side effects or things that you should know about it so that you are the most educated you can be. Now, Clomid can be used, originally it's used as an ovulation induction agent, meaning it is utilized to make you ovulate. Now, we have extrapolated that use for some people who actually do ovulate, and I will go over that. And Clomid has some use actually in men as well. So what is Clomid? Clomid is something called a SERM, or a selective estrogen receptor modulator. The way I want you to think about this is that Clomid comes and binds at estrogen receptors, and therefore makes the body think that there is no estrogen. So if we use the brain as a reference point, what happens when you normally ovulate? Remember that every month you have a group of eggs come out of that vault inside the ovary. Each one of these eggs makes a small amount of estrogen, but not as much as your body needs. So this small amount tells the brain, hi, we need to ovulate, and the brain will send out FSH, or follicle stimulating hormone. FSH is well named because each egg grows inside a follicle, and as FSH rises, an egg will start to grow. As that egg grows, it starts making much more estrogen, and then that high estrogen will peak when you have a mature egg, which will be the trigger for the brain to send out an LH surge and allow you to ovulate. What happens in some people who don't ovulate or don't ovulate well is that the body may not be sending out enough FSH. And part of the reason why can be because the estrogen signal is too high. It is not allowing the brain to interpret that it needs more FSH. And this can be for a multitude of different reasons, just baseline high estrogen, high follicle count, because if you have a lot of eggs inside the vault, you'll have more come out every month, and then you'll have a higher baseline estrogen level. Being overweight, because fat cells can make estrogen. So there's many different reasons why that signal might get misinterpreted. And so you get caught in a place where the brain isn't sending out a strong enough FSH signal, and it doesn't know because the estrogen is high enough. So you just get stuck in this anovulatory pattern. And an example of when we see this is PCOS. That's exactly what happens. And then the ovary gets bored and it starts making testosterone because LH from the brain starts stimulating those cells to make testosterone. And then you get some of the secondary characteristics of PCOS, like acne or hair growth, weight gain, insulin resistance, etc. But if we want to come back and reverse this process at the ovary, really the root of some of the PCOS problems is that you're not ovulating. But people who don't have PCOS get stuck in this anovulatory pattern as well. Clomid will come and then bind those receptors in the brain, and the brain suddenly, instead of having a high baseline of estrogen, thinks it has none, and it sends out a strong surge or signal of FSH. And hopefully this signal is strong enough to get an egg to start growing. Now, you only take Clomid for 5 days because naturally you're just going to have a rise of FSH. You don't need continued high FSH because your body needs the brain and ovary to be able to communicate, because we don't need 8, 10, 20 eggs to grow. We want that FSH to drop as your estrogen is rising so that you only get that one egg to grow. That is the natural feedback mechanism to prevent humans from having these high order multiples. And the truth is, a lot of this requires the brain interpretation. So the lowest dose of Clomid is 50. That's what one pill is. You can go up to 2 pills a day, which is 100. 3 pills a day, which is 150. And those are the studied doses. Some of us will go up to 4 pills a day or 200, just in somebody who might be refractory or not responding. So sometimes you can stair-step patients up, see if they respond. If they don't, go up in dose. Some patients do have an all or none response. And I do tend to find this more in patients who have a higher AMH. They will tend to either over-respond or not respond at all. And this is why some people have to go to IVF, because in IVF, I'm giving you FSH. I'm not relying on your brain interpreting it. And I'm okay, and I want many eggs to grow, because then I can take those eggs out of the body and I can fertilize many embryos and selectively just put one in. When you're ovulating naturally, I have to be very mindful of these high order multiples. And that's really where a lot of these reality shows come from, not IVF, but ovulation induction, where people are ovulating numerous follicles at one time. Clomid was the original ovulation induction medication, and it has been around a very long time. Importantly, It is not standard of care for PCOS anymore. It doesn't mean we don't try it in some PCOS patients, but in PCOS, studies have shown that letrozole or Femara, they're the same medication, is actually standard. But some patients won't respond to letrozole, and we may try Clomid. And it was been used for people with PCOS for a very long time. Clomid also won't work if you have hypothalamic amenorrhea. So if you're not ovulating because your brain is not sending out any FSH, then you already have low estrogen levels and your brain is not doing anything. So coming in and binding your estrogen receptor so your brain senses that your estrogen's low is not going to change the outcome. So also understanding what is behind your anovulation is a very important thing. And maybe it's PCOS, maybe it's hypothalamic, maybe we don't know, but at least ruling out hypothalamic amenorrhea is going to be an important part of this. Because Clomid binds at these receptors in the brain, you may have some symptoms, and some people have none, but other people can have some pretty severe symptoms. And these symptoms essentially feel like menopause because your body is freaking out that you don't just have low estrogen, it thinks you have no estrogen. So hot flashes, insomnia, mood changes, irritability, those are some of the most common feeling emotional symptoms. You also can have lethargy, overall difficulty sleeping. So this is not necessarily pleasant, but it is short acting. Once your body starts growing that follicle, it'll make estrogen and those symptoms will go away. Clomid, because it's a SERM, also impacts other places where there's estrogen receptors. So one of the notable ones can be the uterus. And inside the uterus, you have estrogen receptors. So one adverse consequence of Clomid can be a thin lining. So I like doing ultrasounds when I have patients on ovulation induction. That way I know how their lining looks. Not all doctors do that, but if you've noticed, I took Clomid, but my period was light or lighter than normal, that might be concerning, and you might want to have an ultrasound done. That's an indication to try letrozole or something else because you do need a lining appropriate for implantation. Another thing that Clomid can do is cause persistent cysts because these follicles are growing and then you're ovulating more than other ovulation induction agents. Some people have cysts, ovarian cysts after Clomid. These aren't harmful, but they can delay you. You might have to wait for them to heal before you can do another cycle. And remember, anytime you're growing a follicle or you have a large ovary, you do have a risk for ovarian torsion, which is when that ovary twists on itself and it can be painful in a surgical emergency and you potentially could lose your ovary. So we take that very seriously. Also with Clomid, what we have is there's a very, very small risk based on how estrogen and blood vessels interact of a stroke. And I know that always sounds really, really scary. Remember, estrogen puts some people at risk for that. But the warning sign here is vision changes. So although headaches can be common when you have low estrogen, you shouldn't have vision changes. And if you do, you should tell your doctor and not use Clomid again. Also, with Clomid, really, what are the biggest risks? The big real risks are multiple pregnancy. So 5 to 8% of people using Clomid for ovulation induction will have multiples. So that is what we're mostly concerned about. Most twins do great, not all twins, but we really don't want to see those high order multiples. The higher in dose you get, the higher in risk you have. The other risk is just not responding. So whether it is hypothalamic or refractory PCOS, not everybody will respond to all ovulation induction agents. And this is why in some studies or based on your clinical scenario, your doctor might say you should also use metformin because that can lower some of your testosterone and your insulin resistance and might help benefit with Clomid. Or you might need to use steroids, or you might need to try to lose a little bit of weight if you've tried the max dose of these medications and it's not working. Now, if Clomid is not my favorite option for PCOS, so I like to try letrozole first, when do I use Clomid? It's my drug of choice for anybody who has unexplained infertility and we're trying to super ovulate them. Remember that for unexplained infertility, you have two main treatment choices. One is going to be IVF and the other is going to be super ovulation plus an IUI. And in that super ovulation group, I am purposefully trying to get you to ovulate more than one egg, plus doing an insemination. So I really like Clomid for that. And I'm shooting for between 2 to 4 eggs, really depends on your age. If you're older, I'll tolerate more than if you're younger. I also like Clomid for luteal phase issues. So if you do ovulate or you feel like your luteal phase is short or you're spotting in your luteal phase, I really love a low dose of Clomid because I do feel like it normalizes that out nicely for most people. And if you have very low ovarian reserve, but you're not ovulating well, which sometimes we see as that AMH drops, another situation where I prefer Clomid over letrozole. Some people use letrozole first line because you tend to have a less abrupt response, maybe a lower chance of multiples, but really less side effects. But I really think about if you're PCOS, I'm going to try letrozole first. If you have some of these other indications, unexplained, low ovarian reserve, luteal phase, I will probably try Clomid first. Now, Clomid can also be used in IVF cycles. So in the beginning of an IVF cycle, you might see a burst of Clomid and you might say, why am I using that? The reason why we use it then is the exact same way. It's a complete block at the brain and you will get the brain to send out all the FSH you have. Remember that in IVF, you're using FSH as an injectable hormone. And if I can get away with a couple days of using what your brain is giving me, fantastic. This is not good if you're an average IVF patient because you probably need more FSH than that. But if you are one of two groups, very low ovarian reserve, and I don't need much FSH because you don't have many follicles, Clomid can be a great option. Or very high ovarian reserve, and I am trying not to get all your eggs to grow. So you have a combination of PCOS and hypothalamic, and I'm worried about ovarian hyperstimulation. I might try to come in with something like Clomid to start things off a little slower to purposefully not get all your eggs. Another situation where people use Clomid is for men. In the same way, blocking estrogen receptors and getting the brain to send out more FSH can help men who have low testosterone or low concentration of sperm. It does have some of the same side effects in men, headaches, irritability, emotional, things like that. And it is used differently. It's typically a half a pill every single day. So unlike for ovulation or super ovulation, where we do a 5-day burst, in men, this is a constant daily thing. So Clomid is a medication that has been around a really, really long time. Overall, extremely safe, not associated with birth defects, not associated with cancer or other adverse outcomes. Our biggest risks are truly going to be either multiples or not responding. And then the side effects are really what make it intolerable for some people. But again, some people have zero side effects at all. So if your doctor wants to try Clomid, then just make sure you understand how it works, what you're looking out for. And if you have PCOS, it's not wrong, but using letrozole might be something you want to consider. Okay, guys, thank you so much. If you have questions about Clomid, put them in the comments. We'll keep doing educational videos because I am here to help you learn about your body. As always, I appreciate you. You can learn more on Instagram at Natalie Crawford MD or the